that if you see drooping of the face on one side, our arm is weak on one side, the speech is abnormal, those things indicate the patient might have a stroke. But, inflammation of the facial nerve can also cause drooping of the face. So the important aspect is that it happens suddenly. So you get sudden numbness of the arm, face, and leg, usually all at once, especially on one side of the body, sudden confusion, trouble speaking or understanding, sudden trouble seeing in one or both eyes, trouble walking with dizziness and loss of balance and coordination, sudden severe headache with no cause. And sudden really means sudden. Today I'm watching TV and 2 minutes later I'm abnormal. That's sudden. So the suddenness of the problem suggests that there's a vascular event of some sort somewhere in the brain. The risk factors that cause or predispose one to stroke can be modifiable ones or non-modifiable ones. For instance, age, being male, even being Black African, are increased risk factors for stroke. Those things we can't avoid. But the things we can avoid are the following: smoking, alcohol, increased weight, no exercise, diabetes, cholesterol, age we can't avoid, family history of stroke we can't avoid, being female is also a risk. And if you've had a previous stroke or transient ischemic attack, which means what people call in lay terms a minor stroke. And after you've had a stroke, there is a increased risk for a second stroke. So addressing these modifiable risk factors is important. And the most common effects for strokes are weakness and paralysis of one side of the body, problems with speech and language, poor balance, being unaware of one side of the body, trouble swallowing, problems with bladder and bowel control, problems with memory, thinking, and problem solving, visual abnormalities, and numbness. So you can reduce your risk by stopping smoking if you are a smoker, reducing the amount of alcohol if you drink. If you don't drink, then don't start drinking. Make sure you check and control blood pressure, cholesterol levels, and diabetes. Get regular physical exercise and maintain a healthy weight. So you should actually have regular checkups to check your risk factors for stroke. Support from family members can help if you've already had a stroke. Talk to your doctor about whether taking aspirin in low doses would help reduce the risk of stroke or a transient ischemic attack. Having said that, there's no proof that taking aspirin before you've had a stroke reduces your risk for stroke. But once you've had even a minor stroke, aspirin does have benefit in preventing a second stroke. So it keeps your blood thin and keeps it from forming clots that block the arteries. And if taking low dose aspirin is important, then it's important to follow your doctor's instructions and get the benefit with fewest side effects. Side effects of aspirin are usually bleeding. Regarding nutrition, eat and drink fewer calories per day, limit the amount of salt because that promotes hypertension or high blood pressure. Use healthy fats for cooking, olive oil, canola oil, sunflower oil. Eat healthy foods. To do this, choose foods that are high in fiber. Include whole grains, fresh fruit and vegetable. 5 servings of vegetable and fruit today. The Japanese say you shouldn't fill your stomach up to the fullest. You should leave it 1/3 empty. That's the healthy way of eating. Choose low-fat or lean protein, low-fat cuts of meat, chicken without skin, fish, tofu, beans, and nuts. All those are healthy. Avoid foods that are high in salt, saturated fats, trans fats, foods that have cholesterol. The foods that have cholesterol are usually seafood, like crayfish. Foods that are processed, pre-made. You can count your carbohydrates if you choose to. Regarding lifestyle, if you do drink alcohol, then the limit should be 0 to 1 drink for a female who is not pregnant and 0 to 2 for a male. 1 drink equals a 12-ounce bottle of beer, 350 mils, or 1 5-ounce glass of wine, 148 mils. 1.5 ounces of hard liquor is 44 mils. That's 1. And do not smoke, do not take any drugs, and avoid secondhand smoke. Regarding exercise, you should get at least 30 minutes of exercise on most days of the week, at least 4. Fast walking is good. You can use a bicycle, you can swim, you can garden, that's good. Grow your own vegetables. Regarding stroke care, it's a multidisciplinary effort to treat patients who have stroke. It requires good nursing care to prevent complications, detect problems, and manage these problems. Physiotherapy to prevent venous thrombosis, which is a complication of paralysis. Pneumonia, which is a complication of aspiration. Most people with strokes die because they have aspiration. They don't swallow normally and they aspirate. People don't realize and feed them, and then they aspirate, and that causes chest infections, which then causes mortality and morbidity. Occupational therapy to help with functional aids and prevent contractures, and family education for ongoing support at home. So there are many disciplines involved in the management of a patient with stroke, and a doctor is just one of the aspects. I'm just going to illustrate this. We saw a 29-year-old patient she was in Johannesburg actually, and she was ironing, but suddenly became disinterested in ironing and was non-communicative, slightly drowsy. But she just sat there, and the husband took her to the hospital in Joburg, and they couldn't find what was wrong with her, so he decided to bring her to Durban. And on examination, she had no weakness, she had no sensory disturbance, she was able to speak, but she was not interested in anything. She would just sit and do nothing unless she was led somewhere. She wouldn't even eat otherwise, unless she was fed. And she had a stroke in a particular area of the brain called the thalamus, and this is demonstrated here. It's a specific artery called the artery of Percheron. And so you can see that strokes can present in very unusual ways, only it happened suddenly. This lady was ironing, and suddenly she became somewhat abnormal. And what do we do for people with strokes in terms of drug therapy and risk reduction? Well, we control blood pressure. We treat the cholesterol with a statin if required. We give antiplatelet therapy, and all these trials have supported its benefit. So antiplatelet therapy aspirin is one of them. The other one is clofidogrel. Diabetic control is beneficial, so good diabetic control. And a Mediterranean diet, I've mentioned some aspects of the diet, and the Mediterranean diet is pretty good. Regular exercise, stop smoking, limit alcohol, weight loss. And for people who have a cardiac or heart source of stroke, a clot coming from the heart, we anticoagulate. We give them blood thinning that's stronger than these antiplatelet drugs. We also look at whether they have a source of clotting from the blood vessels supplying the brain, and that is the carotid artery. So if it's very narrow, then we offer surgery. If it's not very narrow, then we do the things I mentioned in the previous slide. So that, in summary, for my brief period, is about stroke, what we do and what happens and how to recognize it. I'm happy to take any questions that people might have. Thank you very much.
Thank you very much,
Stop
Dr.
sharing.
Peter. Yeah, thank you very much for the lovely presentation. And thanks for sticking to time as well. I see there's some clapping going on there. I have checked our chats. I have checked our Q&A. I don't think we have any questions as yet. Maybe people are still warming up. So maybe if you can just stick around until the end, so colleagues might have questions. So what I will do is I will put your email address in the chat, just in case people want to take the conversation beyond this session. So thank you very much.
All right, no problem.
All right. So next, let me share my screen quickly. Okay, our next speaker, please get ready. Okay, to our next speaker. It's Dr. December Mpanza. Dr. December Mpanza is an occupational therapist and an academic leader in the discipline of occupational therapy at the University of KwaZulu-Natal, with a background in leading the occupational therapy department at Abbotsdale Hospital, where he collaborated with the health and disability organizations to enhance community-based rehabilitation. He is a vice chairperson of the executive board of Sanka Durban and founder of Seamless Rehab Occupational Therapy Services. Dr. Mpanza's interest spans physical rehabilitation, return to work, public health, mental health, and substance abuse interventions. His PhD in public health medicine developed an aftercare model for substance use disorders, shifting from an acute to chronic management approach. He established extensively, presented at national and international conferences, and successfully supervised numerous postgraduate students. Dr. Mpanza, over to you.
Thanks, Luther, for a lovely introduction. Much appreciated. Let me share my screen for a few slides. Can I just make sure you see my screen, Luther?
Yes, we can see your screen.
Thank you very much. Greetings, everybody, and to our audience. Thank you for joining us. As introduced, I will shoot straight to what has been asked. I will be just giving an occupational therapy perspective on this interesting topic. But before I dive into that, I want to just briefly define what is rehabilitation. We call this a coordinated process that enhances activity and participation, and it is individualized, person-orientated, activity-focused. Our doctor has given us a good overview of stroke. We're talking about stroke and cardiac. So I will just focus more on the rehab side of things and what will the OT do. So we say it is individualized, person-orientated, and it's activity-focused. So as an OT, my most important aspect of my intervention, it is a person doing things, being able to do what you need to be able to do. So there's this brief explanation of what OT is, which I like to start my talk with, because majority of the time, there is always that confusion. What is occupational therapy? What is this? Is it about work? Which is a misconception. It's not only about work. Of course, it has to do with work, but we define occupation as an activity, anything that you need to be doing. So what we do, our primary goal as occupational therapists is to enable participation in activities. So we achieve this for people or for communities by enhancing occupation and enabling a person to do what they need to do, what they want to do, what they are expected to do. So as all people, there are things that we want to do, and there are things that we need to do, and there are things that we are expected to do. Like work. Work is not really what we want to do. It's what we are expected to do and what we need to do to live. But if we were to check what exactly we want to do, it is actually to be chilling and doing and enjoying ourselves and doing our leisure activities. So we cover intervention for everything that a person wants to do and is expected to do. Now, when you're talking about someone with a stroke or someone with a heart condition, both these conditions are limiting, are disabling. They make you to be unable to do what is expected of you or what you want to do or what it's needed of you to do, which then means your work ability will be affected. Your daily task, everyday activities that we do, bathing, dressing, eating, will be affected. And then we will then try to help through modifying those occupation or modifying the environment so that you better engage in your occupation. So since the topic has been introduced very well, I will just highlight the aspects that are important that we look at. Someone with a stroke or will have a cognitive and perceptual problems that will affect your ability to do what you need to do. Mostly the heart condition will not affect any of your cognition unless there is another problem, but your physical ability will be affected. Your social will be affected. Your spirituality will be affected. You may be even depressed. And then there are things that you need to consider. So since we are talking with the general audience, it is important that we also look at this aspect. When you have someone who have these conditions, check how they're doing socially. If they are socializing the way they should be, check how they're doing spiritually, if they are okay spiritually and emotionally. This is very critical. And for those with stroke issues, check their cognitive ability, if it is okay. Now, the professionals will help you to understand better what is exactly happening with your patient. Now, with your family member or yourself, since this is more of health, wellness, and empowering each other. If you think about someone who has a stroke, and maybe their stroke has affected their perceptual abilities, their ability to see things, to know their surrounding, or their cognitive function. You may think they are no longer interested, or you may think they don't want to do anything, only to find that their cognition is affected. So you have to consider all of that. So if you look at this table or this diagram that I'm showing, stroke will affect all these areas. Your work, as I said, your recreation, all of those areas. Most importantly, your sleep will be affected. A very important part, sleep. If you didn't sleep well, your next day is not going to go very well. Therefore, we come up with a plan on how to assist you and monitor your day activities so that you have a good rest and good sleep so that you are functional on your next day. So cognition, there are many areas that are affected. I'm not going to go through all of them in the interest of time, but I've included them in this PowerPoint intentionally so that when we share the resources, one can read and know what areas will be affected. If we have to talk about the stroke in particular, the left side and the right side, the way it will be affected will not be the same. It depends as to where the stroke is. And there are different levels of intervention that we provide depending on where, at what stage the person is at. And I've included this as well as a resource, just to give people some ideas. If you are managing a family member with a CVA or yourself, on what other things you can look at. Obviously, I want to believe you will be getting help. You will be getting an intervention at that time. So we will look at specifically what activities that are expected of you that you need to be doing. And we will analyze them and we'll see how they affect you, how the stroke or the heart condition is affecting your ability to do those activities. And then we'll design a program that will assist you. I want to show some examples on what can be done. So this is the philosophy of occupational therapy. It is the patient, environment, therapist, and the activity. So these three things during OT intervention, they always interact. Now, to give you some ideas, it's easy when you have someone with a stroke problem, or yourself, you have a stroke or you have a heart condition, to simply say, well, things must be done for me. They must bring everything, they must sort everything. But I want to share some pictures and some ideas on things that you can do to make your life easier, or to make your family members' life easier. You know, this taking a sick role aspect is common when we have these type of conditions, and it comes from a good heart. The family members, they want to help you. They want to make sure you are okay. They regard you as someone who is sick. Now, as occupational therapists, if you have one of the two conditions, we say it's a condition now. There are phases and stages, obviously. Once you are discharged, you are back at home. We don't want you to be regarded as a patient or someone who's sick. We want to regard you as someone who has limitation or a disability. Therefore, we need to encourage you to be able to be independent and assist you to be independent. And as a family member, you can assist someone to be independent by making small changes. Obviously, some of them you will be trained with a therapist on what to do. So we'll assist with the wheelchair, we'll assist with the feeding issues, working together with the speech therapist, as Dr. mentioned, that a lot of patients, they will aspirate. We'll assist with the mobility, and we want people to drive. Pictures that I'm showing are people who are driving themselves with a disability. And this is possible through the intervention. So in all honesty, we want to promote independence. And as a family member, encourage your family member to be more independent by simple things that you can do. These are some of the assistive devices that you can use, that you can, some of the changes that you can do even at home, adaptations that you can make at home. Obviously, the OT will be involved and will be assisting you in changing or in modifying this. So I want to conclude in the interest of time by just indicating return to work, which is usually the bigger challenge when you have heart condition or stroke. And some of the things that we have to do is your workstation. We might need to make changes just so that you are functional. The whole message here is that we want you to be functional despite your condition. And as I said, we will look at what is affected and what you need to be doing. If you can look at the pictures I'm sharing, with the first one, we have a typing splint. The second one, we have the hand grip, because your hand function, your hand ability will be affected. But there are ways we can get around that so that you're able to do your work and you're able to fulfill your duties. So I've added all of these so that you can get ideas and example. What we have there, some spike board, tap turners, things that you can use to enable participation and functioning at home. Program director, I think that is the end of my time. And I want to stop there. Thank you.
Thank you very much, Dr. Mpanza. Before I say anything, I think we do have a hand. I don't know if this is an historic hand. Pravina, do you want to unmute and say something there? See, people are clapping for you, Dr. Mpanza. Pravina, are you with us? Please remember to unmute if you'd like to say anything. Yeah, I'm not sure what's happening there. Alternatively, you can just type your question or remarks, Pravina. And maybe just to remind the other participants that we... Okay. Okay, I think that's a mistake there. Maybe just to remind the other attendees or participants that we've posted the email addresses in case you would like to send emails to our panelists. Thank you, Dr. Mpanza, for that. I am now going to share my screen and then introduce our next panelist. Please get ready so long. Okay, I hope you can see my screen. Okay, so our next panelist, Dr. Takshita Sukenkasi, is a registered biokinetist, senior lecturer and research coordinator in the discipline of biokinetist, exercise and leisure sciences, BELS, at the University of KwaZulu-Natal. A PhD study looked at the effects of combined resistance training and whey protein intake on strength, body composition, immunity, cardiometabolic disease risk, and quality of life in HIV-infected individuals receiving ART. Her goal is to find novel sustainable interventions, such as exercise to decrease the burden on healthcare systems in South Africa and promote healthy lifestyles with emphasis on exercise and medicine. Her broad research aim is tailored exercise prescribed as medicine, TPM. Dr. Sukenkasi has received National Research Foundation's grants and at the University of KwaZulu-Natal, College of Health Sciences Young Researcher competitive grants for novel new method in Africa using microdialysis in determining TPM for type 2 diabetes. Her work in promoting biokinetics has made an impact in the public sector, and she has initiated opportunities for students within the field of the DOH side, which is one of the first in South Africa. Dr. Sukenkasi is also a member of the Biomedical Research Ethics Committee at the UKZN. She has served on both regional and national BASA. Nationally, she has been part of the ethics portfolio, and regionally, she has been the academic representative for almost a decade. Dr. Kasi, when you're ready, please share your screen. The platform is yours.
Hello, everybody. Good afternoon. Thank you for this opportunity to speak about something that is quite close to my heart in terms of my research interest. So we're talking today about the protection of your heart, and I think my area of expertise comes specifically towards the prevention, but I think also towards the rehabilitation or a return to activity or lifestyle. And so I'm going to focus a little bit on the lifestyle modifications for your heart and your brain health. And I actually just, if I could use the word stole, but it was my talk, a few slides from a talk I did recently to a group of family physicians at the South African Academy of Family Physicians conference. And it was basically to try and pass the baton on in terms of calling physicians to action in terms of assessing and prescribing exercise, because they are the first line in terms of treating and working with our patients so that we can get the referrals as occupational therapists, biokineticists, physiotherapists, etc. So there is a host of research that speaks towards exercise as medicine. So using that as a tool, and that's the tool a biokineticist uses. And there's evidence for prescribing exercise in numerous different chronic conditions and managing different healthcare conditions. So basically, I leaned on for this talk, which was looking at the American College of Sports Medicine, which within my field is the gold standard in terms of information provided to practitioners. Sports medicine practitioners, athletic therapists, physiotherapists, and in our country, biokineticists. And they've basically said that there is this world of evidence out there to support there's the inverse relationship between, the inverse relationship between regular physical activity and or exercise and premature mortality, cardiovascular diseases, coronary artery diseases, hypertension, and stroke. And the evidence has resulted from large-scale clinical trials and intervention studies that have been done throughout the world as observational studies over longer periods of time. It is also important to note that looking at cardiovascular health, wanting to improve cardiorespiratory fitness by using modalities such as aerobic capacity or activity has also had an inverse relationship with the risk of premature death from all causes, specifically from cardiovascular diseases as well, and that higher levels of cardiorespiratory fitness are associated with higher levels of habitual physical activity, which has numerous healthcare benefits overall. So I broke this down into what actually causes our stroke or our heart attacks or cardiovascular diseases. And there's a host of different risk factors that come into play here. And one of which is developing a metabolic syndrome per se, which is a combination of a few different conditions, namely diabetes, cholesterol or high cholesterol, and hypertension. So I tried to break this down in terms of how physical activity can work towards individually these conditions. And obviously in my bio, we know that I'm quite interested in diabetes or type 2 diabetes. And the research or the literature out there suggests that physical activity is key in the management tool of any type of diabetes, be it gestational, be it type 1. And obviously in most cases, when we talk about lifestyle changes, we talk about people that get cardiovascular disease or stroke. These individuals are generally older individuals that require more lifestyle changes. And this may assist in preventing any diabetes-related complications, such as insulin resistance, peripheral neuropathies, etc., as well as progressing from an insulin resistance to a full-blown type 2 diabetic condition. So regular exercise undertaken by these individuals results in improved glucose tolerance, increased insulin sensitivity, and a decreased HbA1c. So similarly, if we look at dyslipidemia or high cholesterol, so I know we spoke about cholesterol in the other talks, but it's important to mention that not all cholesterol is created equal and not all cholesterol is bad cholesterol. So if we touch on the bad cholesterols or higher levels of the bad cholesterols, we all have bad cholesterol, but it depends on the levels, and there's norms in terms of what range you should actually try to keep these levels at. So having a high LDL or high density lipoproteins and having a high or very high triglyceride levels can impact health and place an increased risk for cardiovascular diseases and in this case also stroke. So the lifestyle changes again here are the foundation for the treatment of dyslipidemia, even for patients who may eventually progress to requiring a medication, pharmaceuticals in terms of their treatment, right? So the lifestyle changes are the foundation of the treatment for this area of metabolic syndrome and for the risk factor that leads eventually to stroke or cardiovascular disease. Even for patients who, like we mentioned, will require medication, exercise is useful to improve your levels. Although the magnitude of it is sometimes seen as very small, the small differences actually compound to make bigger differences. So again, we don't only talk about aerobic training or cardiorespiratory fitness, there's also resistance training and a combination, and there's a whole host of different types of exercises that can be prescribed. But for example, I'm just touching on some of the evidence of the literature will suggest that aerobic exercise training consistently can reduce your low density lipoprotein by at least 3 to 6 milligrams per deciliter, which is a decent improvement. So then the other aspect of a metabolic syndrome that contributes to your heart and your brain health is hypertension. We know that the contributors for this is not just only lifestyle, but also genetic. But when we talk about lifestyle, and it's been touched on by, I know, Dr. Patel's talk, and I think similarly, Dr. Mpanza, it's high fat, high salt diets, as well as where I come in, where I'm talking about physical inactivity. So chronic aerobic exercise of an adequate intensity, duration, and volume can promote an increase in exercise capacity that overall leads to reductions in resting systolic and diastolic blood pressure of at least 5 to 7 milligrams per mercury at rest or post-exercise, right? And these reductions, specifically in systolic at submaximal workloads, have shown to have prolonged effects on individuals with hypertension. So the literature is present, so we know that not just our diet, although diet plays a big role, but actually engaging in some form of physical activity, exercise, whether it's prescribed, whether it's just taking a walk, can have a significant impact. So if we look at, I thought that we, as healthcare professionals here today, that we would look at what do we consider, particularly when we're talking about our physical activity or exercise, and we take a step back and we think about what is the etiology of the condition. So how will the exercise impact the condition? So it helps in the idea of how to prescribe, how to assess, and how to keep your patient safe, right? So we want to know our patient's history. We want to know what medication they are on. Are there any special considerations? Are they coming to us with numerous risk factors, with a single risk factor? Is it genetic? Is there something to do with their body typing or whether they're overweight or obese? And yeah, touching on the risk factors. And this then leads to the idea of whether they need to go for any exercise testing, whether it's like a stress ECG, for example, and to get a doctor's clearance, whether it's safe for them to then engage in exercise for the health benefits, right? And speaking of a doctor's clearance, this can happen both in a doctor's rooms, but also when you come to your treating practitioner. And in my instance, I'm talking about a biokineticist. We want to do baseline assessments, which include body composition. You can do blood tests, be it capillary blood draws, or you can refer exercise-specific tests to see at baseline where this patient is at, be it a patient that has already suffered a stroke or some sort of cardiovascular disease as well. And then we can obviously continually assess them to see if there's changes or improvements, and that can also lead to adjustments in the exercise prescription. So most importantly, we're looking at what is the physiology, which can impact what we use. Very importantly in our prescription is the FIT principle. And this means the frequency of the exercise, so how often you do it, the intensity, whether you start at a low to a moderate, and then whether you would progress, the type of exercise. I know, as has been mentioned, things like walking, jogging, gardening, and the timing of the exercise. So whether we have to take into conjunction when medication works, when a person has last eaten, what is the half-life of a specific type of beta blocker, for example, whether taking a hypertensive drug can actually impact heart rate, or heart rate may not raise, so we need to take this into consideration in terms of the intensity. So that also leads to this idea of whether the patient requires supervised exercise, and or whether we also need to work in conjunction with other healthcare professionals, such as our doctors, our OTs, our physiotherapists, whether there's a multidisciplinary interaction here as well. So that leads me to just overall to give everybody just a brief idea of what the FIT principle or a version of a prescription would look like in terms of any specific condition. And this one was generally designed towards high cholesterol and our metabolic syndromes, which include your diabetes and your hypertension. And like like Dr. Patel mentioned, he said to exercise on most days of the week. So we're saying greater than 5 days a week. You want to maximize your caloric expenditure. We didn't speak too much about the literature on resistance training. That is an area that I'm actively investigating. So there's definitely a role for resistance training, and also things like your yoga, your flexibility, your balance and coordination, particularly with people that may have had an incident in terms of a specific condition like stroke, for example, right? We want to look at our intensities. we generally start off on the lower end, but we do want to challenge our patients. So you want to maybe look at something more substantial and objective, and we either use our heart rate reserves, and depending on what testing we've done at baseline, where we want to start at about 40%, we want to eventually progress to the higher end to really get the maximal in terms of our cardiorespiratory fitness. In terms of resistance training, you want to start moderate. You want to look at what an individual's maximal 1 repetition max is. And then from there, we want to say, how much can we start them on and how can we progress them? And then we always want to include some sort of flexibility in terms of stretching. The timing, we know that we advocate for anything from 30 minutes to 60 minutes, and you want these individuals to progress. Similarly, with your resistance training, you want to start low and then eventually progress to higher sets and repetitions. And then the type of exercise, there is newer thought processes and new research coming into the play where we don't just talk about walking, cycling, swimming, and there is high intensity activities and other sorts of combination exercises. But basically, you want to give the heart and the body a chance to actually work. So you want to make sure that there is some evidence of changes in the heart rate, changes in the torque. We use the RPE scale to actually identify how much this patient is experiencing in terms of the intensity. So overall, we use the FIT principle to actually guide prescription. And there is generalized prescription basis, but a lot of the time, the goal is to try and give individualized prescriptions here based on more objective measurements, like I mentioned on the previous slide. So yes, thank you. That was me.
Thank you very much.
I'm trying to stop sharing now.
Okay, not a problem. Thank you very much for the lovely presentation. I am checking the chats. I don't think we have any questions, no hands, anything from the attendees before we close. I see there's some hands there. People are clapping for you, Dr. Kasi. And nothing. Pravina's hand is still up. Just the historic hand there. Maybe just to remind the participants that we've shared the email addresses of all the panelists. So if you would like to extend the conversation behind this platform, please feel free. And Dr. Patel left us because he has to rush somewhere to the next meeting. So that was our last speaker, by the way. So thank you very much, all the attendees, for making time to join us. And thank you to Dr. Patel, Dr. Mpanza, and Dr. Kasi. We heard you loud and clear. You educated and reminded us about the heart disease and stroke. You've touched on quite a few things, the causes, the risk factors, when to seek help, lifestyle modifications. And I think it was Dr. Mpanza who reminded us that we need to get some rest. We need to sleep. Sleep is important as much as we are expected to work, but we have to get some sleep. Thank you for the examples that you gave as well, the case studies that you gave us. Thank you so much for that. We appreciate your time and for sharing your expertise. So in terms of the way forward, we will be sharing the recording for those who are interested. So we hope we all go and implement what we have learned, be it in our classrooms, in our different communities, and our daily lives. This is the end of the session. So enjoy the rest of your day, everyone. Thank you once again. Thank you.
Thank you.
Thanks, Luther, for being a good MC.
Thank you.